So this is the lecture for the pathology of the biliary tract. The main reference of this lecture is the 10th edition of the Robinson-Cotran Pathologic Basis of Disease, and I have nothing to disclose related to this lecture. So I will discuss both the basic pathology of the intrahepatic and extrahepatic duct. So anatomically, we have your right hepatic duct and left hepatic duct joining together to become your common bile duct, then become the cystic duct going into the gallbladder, and then part of your common bile duct will extend into the pancreas as well as into the ampulla of Vater in the duodenum. The bile plays a critical role in elimination of bilirubin, excess cholesterol, synbiotics and trace metals such as your copper, arsenic, selenium, and zinc, and its detergent action emulsifies dietary fat in the intestinal lumen, enabling its absorption by the gut. So the major components of bile are your bilirubin, bile salts, cholesterol, and phospholipids, mainly the phosphatidylcholine. Now let's discuss the bilirubin metabolism and elimination. So the first step would be the normal bilirubin production from the heme, and that's about 0.3 to 0.2 to 0.3 grams per day is derived primarily from the breakdown of senescent circulating red blood cells. And then extrahepatic bilirubin is bound to serum albumin and delivered to the liver, followed by hepatocellular uptake, and glucuronidination in the endoplasmic reticulum generates bilirubin monoglucuronides and diglucuronides, which are water-soluble and readily excreted into the bile. This would then followed by gut bacteria deconjugating the bilirubin and degrade it to colorless urobilinogen. The urobilinogens and the residue of intact pigments are excreted in the feces with some reabsorption and excretion into the urine. Serum bilirubin levels in the normal adult vary between 0.3 and 1.2 mg per dl, and the rate of bilirubin production is equal to the rate of hepatic uptake, conjugation, and biliary excretion. Now, jaundice becomes evident when the serum bilirubin levels rise above 2 to 2.5 mg per dl, and depending on the underlying etiology as shown in this table, the elevation can predominantly involve unconjugated or indirect or conjugated or direct bilirubin. So testing for conjugated and unconjugated plasma bilirubin helps determine the cause of hyperbilirubinemia. So again, just to emphasize that a bilirubin normal level is about 0.3 to 1.2 mg per dl, and unconjugated bilirubin is equivalent to indirect bilirubin, while conjugated bilirubin is your direct bilirubin. So in jaundice, the hemolytic jaundice is from unconjugated, while the obstructed type of jaundice is from conjugated. In general, jaundice is due to excessive bilirubin production, reduced hepatic uptake, or impaired conjugation, and to some extent, defective transportation. Many of the causes of your neonatal jaundice is from genetic etiology, like your Gilbert syndrome and your Dubin-Johnson syndrome. But of course, there is massive differential diagnosis if the neonatal jaundice is non-genetic, including the physiologic jaundice of the newborn. With this an overview, we discuss the hepatobiliary disorders that lead to hyperbilirubinemia. So many of these are characterized by cholestasis, which is defined as the retention of bilirubin and other solutes eliminated in bile due to impaired bile formation or obstruction of flow. But in general, we can say that cholestasis is the suppression of bile flow. So before delving into specific entities, We will briefly review the morphologic and clinical features of cholestasis that are common to all. So elevated bilirubin becomes clinically evident as yellow discoloration of the skin, characterized or often referred as jaundice, and sclera as ectorus. So other manifestations include pruritus, skin xanthomas, or focal accumulation of cholesterol, or symptoms related to intestinal malabsorptions, including deficiencies of your fat-soluble vitamins. Elevated serum alkaline phosphatase and gamma-glutamyl transpeptidase, or the GGT, enzyme present on the apical or the canalicular membranes of hepatocytes and bile duct epithelial cells are characteristic laboratory findings of cholestatic disease. Cholestatic hepatocytes are enlarged with dilated canalicular spaces. Apoptotic cells may be seen, and Kupffer cells frequently contain regurgitated bile pigments. Intracellular cholestasis may also show bile pigments in the cytoplasm, and bile plugs may also be present, showing the expansion of bile canaliculus by the bile. Let's now go to the large bile duct obstruction. Obstruction of the large bile ducts have diverse causes. So in adults, the most common causes are stones, or your cholelithiasis, malignant neoplasm of the biliary tree or head of the pancreas. Usually, these are adenocarcinomas, and also strictures resulting from previous surgical procedures or ischemic injury. Primary sclerosing cholangitis, which we will describe later, may lead to an obstructive picture due to inflammatory injury to the large intrahepatic or extrahepatic bile ducts. In children, the common culprits are biliary atresia, cystic fibrosis, and choledochal cyst. The resulting cholestatic changes are reversible if the obstruction is corrected early in the disease course, but persistent obstruction can lead to fibrosis, the so-called biliary cirrhosis. Biliary obstruction also predisposes to ascending cholangitis, which is a bacterial infection of the biliary tree, most commonly caused by your enteric organisms such as your coliforms and enterococci. Cholangitis usually present with fever, chills, abdominal pain, and jaundice. Severe causes can result in abscess formation, sepsis, and even death. Obstruction of extrahepatic or large intrahepatic bile ducts lead to proximal duct dilatation. The hallmark on liver biopsies is portal expansion due to edema, prominent ductular reaction at the portal parenchymal interface, and infiltrating neutrophils associated with ductules, or your pericholangitis. In ascending cholangitis, the neutrophils also involve the bile duct epithelium and the lumens. Persistent obstruction would lead to fibrosis, which can eventually proceed to biliary cirrhosis. Now in this photo, you can see here a demonstration of your biliary cirrhosis. This is a sagittal section of the liver demonstrating the nodularity and bile staining of end-stage biliary cirrhosis. So unlike other forms of cirrhosis, nodules of liver cells in biliary cirrhosis are often not round but irregular, like jigsaw puzzle shapes. So sepsis may affect the liver by several mechanisms. First, through direct effects of intrahepatic bacterial infections such as abscess formation or bacterial cholangitis. Second, from ischemia relating to hypotension caused by sepsis, particularly when the liver is cirrhotic. And third, in response to circulating microbial products. The latter effect is most likely to lead to the cholestasis of sepsis, particularly when the systemic infection is caused by gram-negative organisms. Characteristic morphology in the setting of severe sepsis include canalicular cholestasis and bile plugs within dilated canals of Ehring, and bile ductules at the portal parenchymal interface. This is also called your ductular or cholangular cholestasis. Now, showing here is your ductular cholestasis of the sepsis characterized by large, dark bile concretions within markedly dilated canals severing and ductules at the portal parenchymal interface. Now, hepatolithiasis refers to stones in the intrahepatic bile ducts that can lead to repeated bouts of ascending cholangitis and progressive inflammatory destruction of hepatic parenchyma. At one time, this is also called recurrent pyogenic cholangitis. The disease is highly prevalent in East Asia but is rare in other parts of the world. Its cause is uncertain, but congenital duct abnormalities, diet, and chronic infection with bacteria or parasite have all been suggested as possible etiologies. Chronic inflammatory injury associated with hepatolithiasis is a risk factor for cholangiocarcinoma, particularly in Taiwan and to a lesser extent in Japan. Shown here is a resected atrophic right hepatic lobe with the characteristic findings of hepatolithiasis, including your markedly dilated and distorted bile ducts containing large pigment stones, and there are also broad areas of collapse, liver parenchyma. The physiologic jaundice of the newborn resolves usually by 2 weeks, but infants who have jaundice beyond 14 to 21 days after birth must be evaluated for neonatal cholestasis. The major causes can be grouped under the two broad categories. We have the obstructive biliary disease such as your biliary atresia and non-obstructive etiologies that include the paucity of bile ducts, infectious or metabolic diseases, bile transporter defects, and of course the idiopathic neonatal hepatitis. Now, with recent advances, the underlying etiology can be determined in up to 85 to 90% of the cases. Microscopically, decreased number of bile ducts within portal region profile is the most characteristic and constant features of neonatal cholestasis. The biliary insufficiency often is associated with hepatitis, characterized by inflammation and hepatocellular apoptosis or necrosis. The most striking features are hepatocanalicular cholestasis and giant cell or syncytial cell chains with multinucleated hepatocytes. Reactive Kupffer cells and extramedullary hematopoiesis are usually present. Now this table here is to contrast the main features of primary biliary cholangitis versus primary sclerosing cholangitis. So PBC has a median age of about 50 years while PSC about 30 years. PBC is mainly a female disease while PSC is about 70% male. And you have also the associated conditions like the Sjogren syndrome and thyroid disease scleroderma in PBC and inflammatory bowel disease in PSC. Also take note of the difference in their serologic findings. And in radiology, the PBC is normal while there's strictures in beading of large bile ducts in primary sclerosing cholangitis. And of course, in PBC, duct lesion, the florid duct lesions or loss of small ducts, these are characteristic of your PBC. While in primary sclerosing cholangitis, there is an inflammatory destruction of extrahepatic and large intrahepatic ducts, fibrotic obliteration of the medium and small intrahepatic ducts, and ductular reaction in smaller portal tracts. Let's now discuss the two main autoimmune disorders of the bile ducts. We have the primary biliary cholangitis and the primary sclerosing cholangitis. First is the primary biliary cholangitis or the PBC. PBC is an autoimmune disease characterized by inflammatory destruction of the small and medium-sized intrahepatic bile ducts. Large intrahepatic ducts and the extrahepatic biliary tree are not involved. Most patients are diagnosed in the early stages of disease, and hence the former name is primary biliary cirrhosis, but it is no longer used. PBC has a striking female predilection of 9:1, with a peak incidence between 40 to 50 years of age. Now, the disease is most common in the US and Northern Europe, and the incidence is low in Africa and in the Indian subcontinent. Family members of PBC have an increased risk for the development of this disease. PBC is thought to be an autoimmune disorder resulting from a T lymphocyte-mediated attack on small interlobular bile ducts. The trigger for the attack is not known but may involve exposure to environmental factors like infection and toxic chemicals in genetically susceptible individuals. Antimitochondrial antibodies directed against the E2 component of the pyruvate dehydrogenase complex, or the PDC E2, are the most characteristic findings in PBC. Moreover, antibody titers do not correlate with disease severity or disease progression, and they are not predictive of response to therapy. The hallmark of PBC is lymphocytic infiltration and epithelial injury involving the small interlobular bile ducts. Poorly formed epithelioid granulomas are often present in the portal tracts and can be centered on bile ducts. Take note that the histologic picture of lymphocytic and/or granulomatous bile duct destruction, also called your florid duct lesion, is highly characteristic of PBC. Portal lymphoplasmacytic inflammation and ductular reaction are often present. The bile duct involvement is a patchy distribution, with involvement of a minority of portal tracts being a common feature in early disease. Disease progression leads to the loss of small intrahepatic bile ducts and thus called ductopenia. The diagnosis can be established if two of the following are present: elevated alkaline phosphatase for more than 6 months, positive tests for antimitochondrial antibodies, and characteristic histologic findings. Now, PBC is a slowly progressive disease, and progression to end-stage liver disease occurs in 20% to 25% of patients over 15 to 20 years. In those in whom medical treatment fails, liver transplantation yields excellent result with survival of more than 70% at 7 years. But like many chronic forms of hepatic injury, PBC associated with an increased risk of hepatocellular carcinoma. The other autoimmune cholangiopathies is the primary sclerosing cholangitis, or the PSC. PSC is characterized by inflammation and obliterative fibrosis of extrahepatic and large intrahepatic ducts and dilatation of preserved segments. The presence of circulating autoantibodies and T lymphocytes in the periductal stroma and association with HLA-B8 and other MHC antigens and ulcerative colitis all support the idea that PSC is an immunologically mediated process. But unlike PBC, the autoantibody profile in PSC is not characteristic, but atypical perinuclear anti-neutrophil cytoplasmic antibodies targeting a nuclear envelope protein are found in approximately 65% of patients. In primary sclerosing cholangitis, the large intrahepatic bile ducts and extrahepatic ducts shows epithelial injury and neutrophilic infiltrates superimposed in chronic inflammation. The edema and inflammation cause narrowing of the lumen, leading to fibrosis and strictures. Lithiasis can also develop in the dilated ducts. The inflammatory injury can result in circumferential onion skin fibrosis, also called your periductal fibrosis or sclerosis, around an increasingly atrophic duct lumen, eventually leading to obliteration by a tombstone scar. Now, the smaller intrahepatic bile ducts, which are more commonly sampled on biopsy, are are not directly involved by inflammation, but they may exhibit mild injury and prominent ductular reaction due to cholestasis. Progression of cholestasis and fibrosis culminates in biliary cirrhosis. Now, the gold standard for the diagnosis of PSC is the characteristic beading seen in the large intrahepatic and extrahepatic biliary tree by endoscopic or magnetic retrograde cholangiopancreaticography or the ERCP or MRCP, involving attributable to irregular biliary strictures and dilatations. Now, the disease process typically follows a protracted course leading to cirrhosis over 10 to 15 years. The lifetime risk of developing cholangiocarcinoma is up to 20%. Briefly, the structural abnormalities of the biliary tree are the choledochal cyst, and then we have the group of disease called the fibropolycystic disease, consisting of your von Meinberg complex, or we have also the single or multiple intrahepatic or extrahepatic biliary cysts, as well as congenital hepatic fibrosis. Choledochal cysts are congenital dilatation of the common bile duct. So they present most often in children before age of 10 as jaundice or recurrent abdominal pain, symptoms that are typical of biliary colic, but approximately 20% of cases become symptomatic only in adulthood. In some cases, choledochal cysts occur in conjunction with cystic dilation of the intrahepatic biliary tree, also called the Caroli's disease. The female to male ratio is 3:1 to 4:1. These uncommon cysts may take the form of a segmental or a cylindric dilation of the common bile duct, diverticula of the extrahepatic ducts, or the choledococele, which are cystic lesions that protrude into the duodenal lumen. So choledochal cysts predispose to stone formation, stenosis, and stricture, and even pancreatitis and obstructive biliary complication within the liver. Also, there is an increased risk of developing bile duct carcinoma. Now, three sets of pathologic findings may be seen with polyfibrocystic disease, sometimes overlapping with each other. We have the von Meinberg complex. This is also called a small bile duct hamartomas. So occasional von Meinberg complexes are common in otherwise normal individuals. When they are diffuse, they signal the presence of underlying clinically important fibropolycystic disease. Now, the significance of von Meinberg complex is that this can be mistaken for an adenocarcinoma, especially in frozen section. And then you have your single or multiple intrahepatic or extrahepatic biliary cyst, and when present in isolation, this may be symptomatic due to ascending colitis. Multifocal cystic dilation of the large intrahepatic bile ducts is referred to as Caroli's disease. When the cystic dilation of the biliary tree occurs along with congenital fibrosis, the term Caroli syndrome is applied. And then we have your congenital hepatic fibrosis, which is characterized by portal tracts enlarged by broad bands of collagenous tissue forming septa that divides the liver into irregular islands. Variable numbers of abnormally shaped bile ducts are embedded in the fibrous tissue, although they remain in continuity with the biliary tree. Again, as with cirrhosis, individuals with congenital hepatic fibrosis are at risk for developing portal hypertension and its complications, particularly bleeding varices. So the last topic is the extrahepatic bile ducts and gallbladder. So as much as 1 liter of bile is secreted by the liver per day, between meals, bile is stored in the gallbladder where it is concentrated. The adult gallbladder has a capacity of about 50 ml. The organ is not essential for biliary function since humans do not suffer from indigestion or malabsorption of fat after cholecystectomy. The gallbladder may be congenitally absent or there may be gallbladder duplications with conjoint or independent cystic ducts. A longitudinal or transverse septum may create a bilobe gallbladder. Aberrant locations of the gallbladder occurs in 5 to 10% of the population, most commonly with partial or complete embedding in the liver substance. A folded fundus is the most common anomaly, creating a Phrygian cap. A genesis of all or any portion of the hepatic or common bile ducts and hypoplastic narrowing of biliary channels may also occur. So choledochal cyst, described earlier, may be isolated findings in the gallbladder or associated with other cysts in the extrahepatic biliary tree or with fibropolycystic disease. Now, this is an example of a Phrygian cap. So a Phrygian cap is also called the liberty cap, associated with freedom or pursuit of liberty, used by people during American Revolution and later on during French Revolution. Gallstones or cholelithiasis. More than 95% of biliary tract disease is attributable to gallstones. Gallstones afflict 10 to 20% of adult populations in higher income countries. There are two general classes of gallstones. You have the cholesterol stones containing more than 50% of crystalline cholesterol monohydrate and the pigment stones composed predominantly of bilirubin calcium salts, and each with different risk factors. So cholesterol gallstones are more prevalent in the US and Western Europe and uncommon in low-income countries. The prevalence rates of cholesterol gallstone approach 25% in Native Americans in the US, while pigment stones are rare in these populations. Pigment gallstones, the predominant type of gallstones in non-Western populations, arise primarily in the setting of bacterial infections or parasitic infestations of the biliary tree, as well as in individuals with diseases that lead to chronic red cell hemolysis. Now, the major risk factors associated with the development of gallstones are age and sex, which is mainly a hypersecretion of biliary cholesterol seems to play the major role in both the age and gender differences. Significant associations are also seen with metabolic syndrome and obesity. Again, this is also followed by environmental factors like estrogen exposures. So obesity and rapid weight loss are also strongly associated with increased biliary cholesterol secretions. And you can also develop acquired disorders through gallbladder stasis, either neurogenic or hormonal, and can also be hereditary. There are genes encoding hepatocyte proteins that transport biliary lipids known as ATP binding cassette transporters, which are associated with gallstone formation. In the pathogenesis of cholesterol stone, cholesterol is rendered soluble in bile by forming micelles with bile salts and lecithins, both of which act as detergents. When cholesterol concentration exceeds the solubilizing capacity of bile, or there's what we call supersaturation, cholesterol can no longer remain dispersed and nucleates into solid cholesterol monohydrate crystals. Four conditions appear to contribute to the formation of cholesterol stone: supersaturation of bile with cholesterol, hypomotility of the gallbladder, accelerated cholesterol crystal nucleations, and hypersecretion of mucus in the gallbladder, which traps the nucleated crystals, leading to accretion of more cholesterol and the appearance of macroscopic stones. Cholesterol stones arise exclusively in the gallbladder and range from 100% pure, which is rare, down to around 50% cholesterol. Pure cholesterol stones are pale yellow, round to ovoid, and have a finely granular, hard external surface, which on transection reveal a glistening, radiating, crystalline palisade. With increasing proportion of calcium carbonate, phosphates, and bilirubin, the stones takes on a gray-white to black color and may be lamellated. Multiple stones are usually present that range to several centimeters in diameter. Rarely, a very large stone may virtually fill the fundus. Surfaces of stones may be rounded or faceted because of tight apposition to adjacent stones. Stones composed largely of cholesterols are radiolucent. Sufficient calcium carbonate is found in 10 to 20% of cholesterol stones to render them radio-opaque. Now, the supersaturated cholesterol in bile that forms cholesterol stone may also diffuse into the mucosa and manifest as cholesterolosis. Now, showing here is the gross appearance of your cholesterolosis when you examine some of those routine cholecystectomy specimens. Now, this is what we call their cholesterolosis. So, gallbladder mucosa demonstrate lamina propria distended by foamy macrophages. And this is also associated with cholelithiasis or cholesterol stone. So what about pigment stones? So pigment gallstones are complex mixture of insoluble calcium salt, of unconjugated bilirubin, and inorganic calcium salts. Disorders that are associated with elevated levels of unconjugated bilirubin in bile increase the risk of developing pigment stones. These include chronic hemolytic anemia, severe ileal dysfunction or bypass, and bacterial contamination of the biliary tree. Unconjugated bilirubin is normally a minor component of bile, but it increases when infection of the biliary tract leads to release of microbial beta-glucuronidases which hydrolyze bilirubin glucuronides. Infection of the biliary tract with Escherichia coli, Ascaris lumbricoides, or the liver fluke Clonorchis sinensis increase the possibility of developing these stones. About 1% of bilirubin glucuronides are deconjugated in the biliary tree and in the setting of chronically increased secretion of conjugated bilirubin. A sufficiently large amount of deconjugated bilirubin is generated to allow pigment stone to form. So in this photo, you can see here, pigment stones are brown to black. In general, black pigment stones are found in sterile gallbladder bile, and brown stones are found if they are infected. Black stone contain oxidized polymers of calcium salt of unconjugated bilirubin, while small amount of calcium carbonate, calcium phosphate, mucin glycoprotein, and some cholesterol monohydrate crystals as well. Now, brown stones contain similar compounds along with some cholesterol and calcium salt of palmitate and stearates. Normally, black stones are rarely greater than 1.5, or rather, black stones are rarely greater than 1.5 centimeter in diameters and almost invariably present in great number. Their contours are usually spiculated and molded. Now, brownstone tend to be laminated and soft and may have a soap-like or greasy consistency. And so this is an example of a mixed type of gallstone, wherein both cholesterol and pigment stones are present. So cholecystitis. The inflammation of the gallbladder may be acute, chronic, or acute superimposed on chronic. It almost always occurs in association with gallstones. For instance, in the US, cholecystitis is one of the most common indications for abdominal surgery, and its epidemiology closely parallels that of gallstone. Now, in acute cholecystitis, the gallbladder is usually enlarged and tense, and it may assume a bright red or blotchy violaceous to green-black discoloration imparted by subserosal hemorrhages. The serosa is frequently covered by a fibrinous exudate that may be fibrinopurulent in severe cases. There are no specific morphologic differences between acute acalculous and calculous cholecystitis, except of course for the presence or absence of stones. In calculous cholecystitis, an obstructing stone is usually present in the neck of the gallbladder or sometimes in the cystic duct. The gallbladder lumen contains one or more stone and is filled with cloudy or turbid bile mixed with fibrine, pus, and hemorrhage. When the exudate is virtually pure pus, the condition is referred to as gallbladder empyema. Now, in mild cases, the gallbladder wall is thickened, edematous, and hyperemic. In more severe cases, it is transformed into a green black necrotic organ termed as gangrenous cholecystitis with small to large perforation. How about chronic cholecystitis? Chronic cholecystitis may be a sequel to repeated bouts of mild to moderate acute cholecystitis, but in many instances it develops in the apparent absence of antecedent attacks. Since it is associated with cholelithiasis in more than 90% of cases, the at-risk patient population is the same as that for gallstone. The evolution of chronic cholecystitis is obscure. It is not clear that gallstones play a direct role in the initiation of inflammation or the development of pain, particularly since chronic acalculous cholecystitis shows symptoms and histology very similar to those of the calculous form. Rather, supersaturation of bile predisposes to both chronic inflammation and, in most instances, stone formation. Microorganisms, usually the uh, E. coli and enterococci, are cultured from the bile in about one-third of cases. Unlike acute calculous cholecystitis, obstruction of gallbladder outflow is not a prerequisite. Now, the morphologic changes in chronic cholecystitis are extremely variable and sometimes minimal. The serosa is usually smooth and glistening, but may be dulled by subserosal fibrosis. Dense fibrous adhesion may be present that represent the sequelae of prior acute inflammation. On sectioning, the wall is variably thickened and has an opaque gray-white appearance. In complicated cases, the lumen contains green-yellow mucoid bile and usually stones. The mucosa itself is generally preserved. Now, on histologic examination, the degree of inflammation is variable. In the mildest cases, only scattered lymphocyte, plasma cells, and macrophages are found in the mucosa and in the subserosal fibrous tissue. But in more advanced cases, there is marked subepithelial and subserosal fibrosis accompanied by mononuclear cell infiltration. Reactive proliferation of the mucosa and fusion of the mucosal folds may give rise to buried crypts of epithelium within the gallbladder wall. Outpouchings of the mucosal epithelium through the wall may be quite prominent, and this is called your Rokitansky-Ashkoff sinuses. The significance basically of Rokitansky-Ashkoff sinuses is that these can be mistaken for an invasive adenocarcinoma. So it is important that you have to check the presence or absence of mass within the gallbladder. Now, in rare instances, there is extensive dystrophic calcification of the gallbladder wall. We sometimes call that as your porcelain gallbladder. More often, there is complete replacement of the gallbladder wall and mucosa by dense fibrosis, and this is called your hyalinizing cholecystitis with or without calcification. Take note that this change is notable for being associated with an increased incidence of gallbladder carcinoma. And lastly, let's go to the carcinoma of the gallbladder. Carcinoma of the gallbladder is the most common malignancy of the extrahepatic biliary tree. Gallbladder cancer is at least twice as common in women as in men, and this gender disparity can be several-fold greater in regions of highest incidence. The overwhelming majority of patients are diagnosed at an advanced age, surgically unresectable, and the mean 5-year survival rate for affected patient is less than 10 years. The most important risk factor for gallbladder cancer is gallstone, which are present in 95% of cases. However, it should be noted that only 1% to 2% of patients with gallstone develop gallbladder cancer. In Asia, chronic bacterial or parasitic infections have been implicated as risk factors, and the coexistence of gallstones with gallbladder cancer is much lower. Nonetheless, the common thread that ties gallstones or chronic infections together with gallbladder cancer is chronic inflammation. So several precursors of gallbladder carcinoma have been described, indicating that as typical of carcinoma generally, full-blown cancer likely arise from a lengthy, stepwise process. These precursors include your flat in situ lesion with varying degrees of dysplasia, your mass-forming adenoma-like lesions called or termed as intracholecystic papillary tubular neoplasm and intestinal metaplasia. Gallbladder cancer are mainly adenocarcinoma and are most often detected in the fundus. This may produce a firm, poorly circumscribed mass or may diffusely infiltrate the wall of the gallbladder, simulating the gross appearance of chronic cholecystitis. So microscopically, as shown in this photo, they are usually characterized by the presence of glands embedded in desmoplastic stroma, but in some cases, um, cytologic atypia and stromal response are minimal. Now, in these instances, identification of perineural and vascular invasion is very important. So other variants of gallbladder carcinoma would be your neuroendocrine tumors, squamous cell carcinoma, and sarcoma. So most patients have advanced disease at the time of diagnosis, and the overall prognosis for these patients is poor, even with apparent complete resection of the tumors. So adjuvant chemotherapy is often offered to such patients, but it's not curative, and most patients eventually succumb to their disease. Let's take a look at the review of this article entitled Precursor Lesion of Gallbladder Carcinoma, Disease Concept, Pathology, and Genetics. So, as in most epithelial cancer, the development of gallbladder adenocarcinoma is preceded by a variety of precancerous changes. However, compared to other organs such as your colon, uterus, prostate, and pancreas, knowledge of the precursor lesion of gallbladder carcinoma is very limited, and their clinical pathologic features are insufficiently characterized. Now, this is partly due to the rarity of these lesions. So controversies about the criteria for diagnosis and the use of several unified terms when referring to the lesions were discussed in this article. These are some of the examples of such precursor lesions. This is the pathology of biliary intraepithelial neoplasia, or BIL-IN. So showing here, using H&E staining, in letter A, we have a low-grade biliary intraepithelial neoplasia. Seen next, a high-grade biliary intraepithelial neoplasia component. Letter B here shows the high-grade biliary intraepithelial neoplasia lesion with pseudopapillary eosinophilic epithelium, showing also the toughing and atypia pattern. While letter C is a high-grade biliary intraepithelial neoplasia with adenoma-like pattern. Letter D is a high-grade biliary intraepithelial neoplasia with micropapillary pattern. Now this shows the pathology of gallbladder of patients with pancreatico-biliary maljunctions. Letter A is a resected specimen of gallbladder and dilated bile duct, while letter B is a gallbladder mucosa showing diffuse papillary hyperplasia. Letter C is also a diffuse papillary hyperplasia in a 2-year-old girl with pancreatico-biliary maljunction. So that's the end of the lecture. Thank you.